Simon. Thank you. First of all, I'm amazed that anyone showed up here tonight because the weather is so terrible and another tough evening in Toronto. But I appreciate. I told my wife I didn't think like 5 people would come, so I'm amazed looking around the room. This evening, it's my great pleasure to speak to you, and many of you feel like family to me because I have seen you in the other building across very close to here. So nice to see everyone again who I've had the opportunity and pleasure of looking after over time. So I want to talk today about how to do new things. And when I was a kid, I was just about, I guess I was about 9 years old, or 11 years old actually at the time. Robert Kennedy was killed. I think most people in this room will recall that. And during the funeral, his brother, Ted, gave an incredible eulogy. And I remember it now because it had quite an impact on me, what he said. And he used these words. He said, when he was talking about what his brother felt about life, that some men see things as they are and say, why? I dream things that never were and say, why not? And it truly resonated with me at the time. I didn't realize at that time that Ted Kennedy himself had not actually made those words up. He didn't say who did, but this is the individual who did say that. Does anyone recognize who that is? Anyway, that's George Bernard Shaw. So, and you know, I hope as I go through this talk, you'll see that it is a motivating factor behind people, not necessarily me. I like to think that I think this way, but people who really try and develop new things that it's not trying to understand sometimes why something is the way, but why can't you do something completely different? And I hope that will come through in the talk. So you're not used to doing angioplasty. I guess if you watch that Twitter today, you could do surgery now. But I wanted to teach a little bit how to do angioplasty in about 4 lines. So the first part is that you have to cross the blockage with a very small guide wire, and it's 14/1000ths of an inch. So it's very, very tiny. In fact, I forgot, I'm sorry, I was going to bring one here and pass it around to show you how small these tiny little guide wires are. But they're a little bit thicker than a hair. They're very, very small. Secondly, once you get that guide wire across the blockage, then over the guide wire, you advance a balloon or a balloon containing a stent. And then you inflate the balloon, which then allows the stent to come off the balloon and anchor itself in the wall. And when you do this in situations where the artery is narrowed but not totally blocked, we are incredibly good at doing that, angioplasters. We have about more than 95% success rate. And I could take you in there for an hour or so, show you a few, and you could probably do it close to that rate as well, because the equipment is amazing and it's a very successful and quite straightforward procedure, though there are complexities to it. And the reason is that you can always get the guide wire where you want it to go, because you can see the pathway that the guide wire has to travel. However, what I'm going to be talking about this evening is what is really my greatest frustration, which is chronic total occlusions. And you can see the arrow that's pointing right here. This is a circumflex artery, and it should be running all the way down here. And this is a branch of it, but it is completely occluded. And that is when it becomes quite difficult to do angioplasty. In fact, when we do attempt these angioplasties, and most of the time, as you'll see, we don't even try, our success rates are not 95%, they're somewhere between 50 and 70%. And the reason that we cannot be successful is that the guide wire cannot penetrate through the hard material that's blocking the artery. So there should be a nice channel through there, however it's blocked by the material in there, and the guide wire won't go through. And that's a great frustration. And our usual strategy in cardiology, we're sometimes a little bit of a simple group of people. If something won't go through with a regular guide wire, we say, well, let's just get something that's way stiffer and way harder, and we'll just poke through way more aggressively. The only problem is if you take stiffer guide wires, sometimes they work beautifully, but other times they may go in places you don't want to go because you're forcing them through arteries that are resisting them because of the hardness. And you can perforate the artery, you can get yourself into a little bit of trouble. And once in a while, unfortunately, I have faced that myself. So I figure there's got to be a better way to do it. And when you're doing these procedures, normally in angioplasty, and those who are in the room, if they can remember, because we usually sedate you a little bit, we get it done in about an hour. You know, from beginning to end, it's about an hour to get it finished. But when you're doing these angioplasties of totally blocked arteries, because they're so challenging to get the guide wire through there, you can be in there for a few hours. It can be 3, sometimes 3.5 hours. And even after that period of time, you may not even have been successful. So the patient has been lying on the table for many hours. You have given a lot of contrast, the X-ray dye that we use, which can be harmful to the kidney. And as well, they've taken a lot of X-ray radiation, which can cause problems as well when you're using the amounts. It's about probably 3 or 4 times more than we do in a usual case where it's narrowed but not blocked. So we need a new answer to this. So this is a famous saying that Will Rogers said, that good judgment comes from experience, and a lot of that comes from bad judgment. So, and I must say that over the years, that probably really describes my career as an intervention cardiologist, because you learn a lot from your mistakes. So what is it like doing angioplasty? And this picture, I think, shows it very nicely. This is a coronary catheter. This is what we inject the dye through. Where the yellow arrow here is, that's where the artery should be. And what we're trying to do is get these guide wires to go through this area where you cannot see any artery, and to the point we're going blindly. We don't really know exactly where we're going. We think we know where we're going. And at the end, you want to try and achieve something like this. But you can see here that there's no real pathway that you can see to go through. So you either have to have a good feel of where you should be, or you have to have a little bit of luck. So those who are experienced in it, we try and do that, but it can be very challenging. So what I'm going to be talking about then are these blockages, what we call as chronic total occlusions. And I want to explain a little bit to you. If you have a sudden total blockage of a coronary artery, if it happens very suddenly, we call it a heart attack. And that's usually thrombus or clot that blocks it off. And that's usually very soft material and very easy to get through. Okay? However, if the artery's been blocked for months or years, the material gets very hard, and the patient may continue to have symptoms because they actually did not have a heart attack from it. It blocked up so gradually that they had enough collaterals from the other arteries that the heart muscle itself remained alive, viable. But unfortunately, because there's not enough blood going through that area, they have symptoms, typically angina, chest pain, or shortness of breath. So a chronic total occlusion, what I'm going to be talking about, I'm going to use this acronym called CTO, and you're going to hear it a lot as I go through it. And that's an artery that's blocked totally for at least 3 months or longer, and in many cases it's been for many years. Okay? And what does it look like? Well, this is what a normal coronary artery looks like. This is the wall of the artery. And this white stuff here, that's the channel that all the blood goes through. And this is one that doesn't have any plaque in it. It's a very nice, healthy-looking artery. And there's a lot of room there for the blood to go through it. However, when you get a chronically blocked artery, or CTO, this is the type of the way that there's different ways that it looks, because there's different material that fills up this where the lumen, or where the blood should be flowing through. And it can be, this just shows the range of material that blocks it up. And in some ways it can be material that's not that hard to get through. And these are these little tiny micro vessels, or little tiny arteries that are inside the artery, that in some cases can actually cross right through the blockage, and you can find one of those arteries. It's like surfing, and you get the wire to go into that little passage, and it'll go all the way through there, out the other end, and then you can fix it. And this is a very helpful way to get through it, and these type of blockages you do very well. Most of them look more like this. They have a lot of collagen. I'm going to talk about collagen because that's the basis of the invention that I've been working on for the last 14 years. And in some cases, you may see what I call just the plain old ugly. And that's calcification, and that's very, very rock-hard material, much harder than collagen. And unfortunately, my invention doesn't work on calcification, but usually there's a mixture of collagen and calcium within these arteries. And so if you can work on the collagen part, you can usually get around where the calcium is. But in some cases, the calcium is so thick and so hard that there's really nothing you can do to open them. So what is the current way that we treat these chronic total occlusions? Well, if patients are asymptomatic, in other words, they really don't have shortness of breath, they don't have chest pain, most of them really do not need any special treatment unless they had some very ugly looking blockage in the beginning of their heart, such as a left main coronary blockage. But most of the time, the majority of patients who are asymptomatic, you don't have to really do anything when you find it. And as a consequence of that, over 2/3 of the patients that have a chronic total occlusion are treated with medication. They don't need a procedure to open it. Now, unfortunately, many of those 2/3 actually have symptoms, but because it's so difficult to open these arteries, the doctors sort of say, well, it's really too tough to try it. I'm just going to leave you on some medication, and sorry if your life is limited, but it will, you can live with it, but you just won't be able to run around and do all the things you like. And about 25% of the patients with these occlusions undergo cardiac surgery because the surgeons don't really care whether the artery is narrowed or it's completely blocked, because they go well beyond where the blockage is to put their bypass. But if you want to do angioplasty, and angioplasty is a much easier way for patients to recover and to continue on with their life, these are very challenging. And unfortunately, at the present time, less than 10% of all the patients with chronic total occlusions are treated by angioplasty, and even when we try them, our success rate is relatively low, so about 50 to 70%. So if you ask, well, is this a problem? Like, a few people have it. Well, you'll see, I think, that it's really substantial. It's a substantial problem. There are a lot of people who have chronic total occlusions, and each year in the United States, if you look at the data, there's about 1 million new occlusions that are diagnosed from angiograms. More than 1 million each year in the US, and probably about 2.5 million each year. That's not a total at that time. That's new cases that are diagnosed. And the way you diagnose them, of course, is by doing an angiogram. That's how you tell whether it's there or not. So there's a lot of people that have it. And as a consequence of the problems, there is a lot of research for new solutions to assist us to advance these guide wires through the blockages without harming the patients and enabling us to put stents and open the artery. And the point of trying to do this is, first of all, it's like pushing through concrete, and it really feels hard. You can feel it even though you're 160 centimeters away from the tip of the guide wire. You can actually feel the hardness of the lesion. The conventional type of guide wires are usually too soft and they won't go through them. And some of the newer wires, as I told you, are much stiffer, and sometimes they're very helpful and they can get through them, but they are a little bit scary for some interventionalists because they have increased risks and you can do some damage with them. So why would you bother doing angioplasty in patients? Why should we work on it? Well, first of all, once you are successful, you can really relieve angina and improve chest pain and shortness of breath, and that's a tremendous benefit to patients. In some selected patients, in fact, they may have a weak heart that if you open up the total occlusion, the heart gets better and gets stronger, and as a consequence, they'll have much less heart failure. The third point is, if you can open it by angioplasty, you don't have to, I think you would not have to undergo bypass operations. And in fact, the ratio of bypass operations to angioplasty, which is 3 to 1 or 2.5 to 1 for chronic total occlusions, is the opposite of almost every other coronary blockage that we look at. So we're doing, at Sunnybrook, we're doing 100 angioplasties a year, a little bit more than that. Surgeries, we're doing about 600. So it's about 3 to 1 the ratio, except when you get to this problem of chronic total occlusions. We're not sure at this point whether if you open them you can reduce mortality. I think there's a lot of research to do in this field. There is some data to suggest that may be the case, but we're not yet at that stage. Okay, so how are we treating them currently? So in the coronary arteries, angioplasty 12%, actually it's under 10%. Bypass about 1/4, medical therapy about 65%. And these blockages, not only do they occur in your coronary arteries, but they occur in the arteries in your legs. And the main symptom of that is when you try and walk, you get pain in your legs. And they're also as common in the legs as they are in the heart. And very few are treated by angioplasty, and even fewer are treated by surgery. So over 80% of patients who have these blockages in the legs are treated with medication because they say, well, you can live with it, you just can't walk as well. But in fact, many people, if they could open them, would have a much better lifestyle. By the way, if you want to ask me a question as I go along, feel free, don't be shy. I'm happy to answer any questions. So which patients to treat? Well, if you have symptoms, as I told you, those are patients I think that we should consider treatment. If the tissue is alive, now some patients who have heart attacks, big heart attacks, if you go and do an angiogram a year later or 2 years later, their artery will probably remain blocked, right? So that also is a chronic total occlusion. But in that case, the heart is dead from the heart attack, so there's no real benefit in doing it. However, I'll tell you that 80% of patients that have these chronic total occlusions have either no heart damage or minimal heart damage. So you're only looking at about 20% of patients. And some of that 20%, if you open the artery, in fact, their arteries will get better. And I'll show you how we indicate which of those patients there are. So how do you tell if the heart muscle is alive even though the artery is blocked? Well, the cardiogram's helpful because it shows either the presence or absence of an infarct on the cardiogram. The echo can show you whether the heart muscle is normal or not. And the best way when there is some abnormality on the echo to see whether the muscle is actually alive is to do an MRI. And so we do, anyone in this room ever had a cardiac MRI? So this is becoming much more popular and much more important. And this is one of the great uses of MRI, is it tells us if the heart muscle is actually alive or not. So there's a lot of importance in terms of determining whether there's viability in some patients before you try and open up these chronic total occlusions. This is a picture of an MRI. This is something, I'm not going to talk about the physics about it. I don't understand it. It's well beyond me. But if you see it as a picture here, I think it's very easy to understand. So this is the heart wall itself, all the gray stuff here. And the white part is where the chamber of the heart, where the blood is. So if you inject a tracer called gadolinium, it will deposit itself in the wall of the heart. So here's the wall before we put the gadolinium. And this is after we've injected the gadolinium. And if you image the heart about 20 minutes after you've given the gadolinium, or 10 minutes later rather, you will see that there is an area in the wall that's white and an area that's black. Okay, everyone can see that? It's clear, right? It's not so complex. So all you really need to do is you look at the thickness here of the wall from here to here, and you take how wide it is, the white part, and divide that over the whole part of the wall. And if that is the white part, which is the scar, so that's the part that won't get better. If that white part is more than 50% of the thickness of the wall, then it's unlikely to get a recovery of heart function after. So it's a very complex technology, but the actual analysis of it is not so you don't have to be a rocket scientist to be able to figure out what A is across and what B is and just do the ratio. So that's how we do it.
Is that MRI different than the nuclear medicine?
Yes. Yeah. The MRI, the nuclear is another way to do it, but the gold standard is MRI. That's the best way. And this is how we do it. And we do this often at Sunnybrook. So in the days prior to, let's say, 10 years ago, patients in here, I know everyone, I usually don't ask people what they have because there's confidentiality, but it looks like your group is not that worried about sharing information. So a few of you put up your hands for having stents. Do you know whether or not you had a bare metal stent, which is an unmedicated stent, or a medicated one? Most of you, okay. So if you had an unmedicated one, just put up your hand, okay? And if you had a medicated one, okay. So that's a whole story in itself, who gets a medicated one and who doesn't. But I'm going to tell you the short story. Yes?
How do you find out?
You ask the doctor. They should tell you. It's easy. Did I get a medicated stent or did I not?
No.
Just ask them. Usually they tell you. So first of all, we had unmedicated ones, and then later we developed these medicated ones. And the big story here is that when we put unmedicated ones in these blocked arteries, they had a lot of restenosis. So they would re-narrow up very frequently, and quite often they would actually re-block again totally. That was the problem with bare metal stents. And these are what stents look like. Looks like I don't have to tell anyone here. This is the size of them when it's on the balloon, and then after it's been opened. Here it's showing inside the artery. So these two different types of stents, and if you're going to get a medication, most of them are what's called a derivative of limus. There's rapamycin, which is one of them. There's everolimus. There's a whole series of them that have a similar type of drug in the wall of the artery, or rather within the stent wire on the surface of the mesh, and it's released over time. And the reason it's really good for this is it decreases the restenosis rate from more than 50% to less than 10%. So before, even if first of all, you probably weren't going to be done because the doctor didn't think he was going to be successful. Then if he picked you to do it, there was a good chance you wouldn't be successful. Finally, he gets successful, puts in a lot of stents because they take a lot of long stents, as you'll see, and then it restenoses up. So there are all kinds of reasons not to do it before, but now because these stents are so good at preventing that, that's really not a reason to try to do it nowadays. Yeah.
How far back did the drug-eluting stents come into play?
I mean, when did we start to introduce them? They probably started around the late 1990s, early 2000. Probably they were very expensive in the beginning, so we had limited use of them. And from about 2003, 2004, 2005, they started to become quite spread out in use. There was a little bit of scare about them, about there being high risk of them blocking up and causing heart attacks after a couple of years. I think that fear has really dropped off. And so now at Sunnybrook, we probably use the medicated stents in about 70% of the cases we do. And about 30% are the bare metal ones. And there's reasons to do one or the other because you're committed for a longer period of time with the blood thinners if you have the drug-eluting stents, these medicated ones. But if you're going to do a chronic total occlusion, you really have to use a medicated one because the restenosis rates are really prohibitively high otherwise. Cool? So this is the situation what it's been like for many years. I told you that some of the progress in this field has been that they have developed these guide wires. And although some of them are very stiff and a little bit dangerous, if you're skilled in using them, they can be used very effectively. So they can really they can do cases that you could not do before. Next, they developed very, very soft wires, just the opposite. And the reason is that these soft wires can somehow get into these small little channels, like these small little arteries that run through it. And in some cases, you can make your way through the occlusion through these tiny little rivers that run through it. And so a very soft one goes nicely in there. So the very hard ones are helpful, and the very soft ones are. There have been new techniques called, and the one I'm going to show you is the retrograde. I don't expect you to do it after you've seen it. It's very complex, and once you see it, I think you'll probably understand why it's not hugely popular with interventional cardiologists because of the complexity of doing it. Developed by the Japanese, as many of the guide wires are. In fact, most of the progress in this field has come from Japan, where they have a great reluctance to undergo bypass surgery. So there is a great impetus to try and find ways of opening up these chronic total occlusions. There's a new device that's available called a cross-boss Stingray, which I'm not going to talk about, but is starting to be used. And then finally, I'm going to talk about mine, changing the plaque, which is collagenase. We'll get into that shortly. So new guide wires, I don't think any picture really, you can appreciate the guide wire, how complex they are. That's very much magnified, so when you're looking at them, they really don't look like that. They just look like a little piece of wire. And as I mentioned before, there are stiff tip guide wires for pushing through hard material. The issue there is safety, and there are soft tip ones for finding these small little microchannels. I'm going to talk to you a little bit before I talk about the collagenase, and that'll be the main part I want to speak to you today, about this retrograde technique, because you may start hearing about it because it's becoming increasingly used, although still not very many operators do it. Originated in Japan. And as you will see, the idea of this, or the concept, is not to go forward through the occlusion, but to access the artery on the opposite side, go through that artery, through a connection, because there's often what we call collaterals, which join up where the artery is beyond where the blockage is to the other artery that's healthy on the other side. So you go backwards and you come up through the end of the artery back up the front. So it's instead of going antegrade, you're coming retrograde. That's how it gets this name, retrograde. And you'll see that it is a little bit complex. So I'm going to run you through here. Okay, this is coronary angiogram, and one of the first things that you have to see about how we do these procedures, and just showing a little bit of the complexity of it, is that instead of having just one tube or one catheter in place, we actually have two. So either you have to go through both groins, or you go through one groin and one wrist. Most of the procedures, almost all the other procedures we do, you just use one. Okay, so you need to use two here. So one catheter here is sitting in the left coronary artery, and the second one here, catheter one, is in the right. Now here, you will see that the artery this is the right coronary artery. It's narrowed, it has disease, and all of a sudden you get to here, and it's completely blocked. Can everyone see that up there? And it says entry here. That's where I've written entry. Now, where the artery is reconstituted is where it says exit. So the occlusion is all the way between these two arrows. Everyone clear on that? Now, the left coronary artery is this artery here, and I'm not going to go through the names, but you can see that there's a connection between the artery on the left side and the distal end of the right coronary artery, which is beyond the occlusion. And these are little collaterals that run usually through the septum of the heart. They're not usually there unless there is an occlusion. That's when they form at that point. And if you can go through the main artery and then through these septal, these collaterals, you can end up in the back end of the artery, beyond where the occlusion is, and then you have to come back up the other way. So you can see here in this second panel that the guide wire is now going through even though the occlusion is in the right coronary artery, here's the guide wire coming down the main artery on the front. Now you go off on a side branch called a septal. You go right through the septum, through the distal end of so you go all the way through that connection. Then you make the turn around and you come back here. So now you're at this point. So you've made all the way through there. Can you imagine? It's really a backward, and it's complex to do that. Now once you do that, you can then take a second wire now down the right coronary artery, and you can see this is the wire, the second wire. So you have one wire down the left coronary artery, through the channels into the distal part, a second wire into the right coronary artery. Is it getting complex or not? Okay. So then in this case what we did is we put a stent over where that second guide wire is. We deployed that stent, and now we brought this wire, and as you'll see, we tried to fit it inside where the stent is. So then we had a nice clear pathway out the rest of the artery. And you'll see that here. Okay, so now the stent is in place. This is the one wire, the second wire, and this is the stent. If you can see the outlines of the stent here, it's a little bit gray. Now this artery that came through the left coronary artery came all the way across through the occlusion. Now it's found its way into the stent. Now we've put us all the way up in the stent into the other catheter. So it's now come out one catheter, all the way down the one artery, through the septum, back up through the blocked artery, and into the second catheter. And then you have to take it outside the body. So now if you're working at the patient, you have one end of the wire on this groin and the other end of the wire on that groin. Okay? Is it complicated? Yeah. No, it's very good. So then once you have that, then you can do the procedure. You can move all the catheters and balloons, and you can get a nice result like this. And you see the artery is completely. Now you can maybe get a feeling from that explanation why a lot of people wouldn't be running down the hallways to try and learn this technique, because there's lots of little steps in here where you can get into big time trouble, and it's very challenging to get the wires across. Okay, so that's the background. Now we're into the fun stuff. So I wanted to really think of a new way of treating these. As I told you, I failed so many times it was very frustrating for me. And I decided that instead of taking a harder guide wire, which is the usual way we think as angioplasters, if you can't get through there, just get something harder. I said, why don't we change the way the hardness is of the lesion? Instead, take a different approach. Instead of taking a harder wire, make the material softer. And that's the whole, the basis of the rationale of what I'm doing. And what is it that's actually making it so hard? Well, it's collagen. Everyone in here heard about collagen? Yeah? Okay. Okay, so you know what I'm talking about, right? You've read it too. So collagen is a very important component of these chronic total occlusions. And here you can see, can everyone see the normal wall of the artery here? This is from a patient, unfortunately died. Now you can see here inside where the channel should be, there's now just a tiny, tiny little channel that on an angiogram would look probably completely blocked, or maybe a very, very small microvessel. But all this is collagen. So collagen is the main constituent or the main part that you find in these arteries. Now, if it's an acutely blocked artery like a heart attack, it'll be clot. But over a period of time, that thrombus or clot is replaced by collagen, and that's the main material that we find. Now, most of us may have heard about collagen in other ways, and it's been injected into all kinds of places, and you really don't want to inject it into your heart. But collagen is something very, there's a huge market of collagen injections in the world. Now, so we've talked about collagen. Now, if you want to get rid of collagen, you have to find something, and you'll see it's an enzyme that breaks it down. And the smart thing about it is that the name of it is collagenase. So collagenase means it's an enzyme. The ASE part means it's an enzyme. And it acts on collagen. So I'm not giving collagen, I'm giving an enzyme that breaks collagen down. Okay? That's the idea of the collagenase. And it's an enzyme, it protolyzes, and it's a chemical reaction that just will split the collagen, break it down, and make the artery much softer. And the way we make the collagenase is, humans make collagenase. We all have it in our body. But the best stuff, if you really want to get the best collagenase around that works on human collagen, is not human collagenase, actually. It comes from a bacteria called Clostridium histolyticum. And this particular type of collagenase is more effective than human collagenase in breaking down collagen because it acts at many more sites. And the way you get this collagenase is you take the bacteria, you grow it up, and it makes it makes like a soup of stuff, all kinds of enzymes. And inside that soup, one of the main ones is collagenase. And you'll see that we have to isolate the collagenase from the soup. And what we end up doing is we inject the collagenase part of the soup. We don't inject the bacteria, so we have to be very careful to make sure there's no bacteria in there, because obviously we wouldn't want to inject a bacterial product or bacteria, but just what they make, which is this collagenase. Okay? And it's taken me, as you'll see, 10 years of work to get it to the point of where I can assess it in humans. It's a long process, and I think you'll see that. And now I think we have it at the way that we have enough that it degrades the collagen and softens the plaque in the artery, but doesn't damage the wall itself, because there is collagen normally in the wall, and if you were too aggressive with the collagenase, you'd destroy the wall and maybe cause aneurysms or cause terrible trouble. But if you give the right amount of collagenase, you can actually soften the plaque without damaging the wall. And I'm just going to give you just a little bit about what it's like doing innovation, because it's been a very long road for me. And this is, anyone know who this guy is? Does anyone recognize? Well, this is Kristers Gudlevskis. I probably butchered the translation, but he is the Latvian goalie who stopped 55 of 57 shots for Canada, against Canada the other day. And that's what I feel like most of the time. When you try to invent things and move things along, the amount of obstacles you hit, you have to be an extremely stubborn individual, or maybe a little bit stupid, because there's so many steps along the way, and there are a lot of cynics, and there's a lot of difficulties and problems, and I'll probably show you a little bit of that road, but it is, I would not say in any way it's a nice, smooth, easy road, and not for the faint-hearted, that's for sure. So I first came up with this idea around late 1990s, and that's, how long is that now? Is that 15 years ago? So I was a young guy then. So, and in the beginning, I had this idea that you could do this collagenase, but I had no way of testing it. First of all, I didn't know how much to give. I didn't have any models. You can't just go and say, you know what, I don't want to get that collagenase off the shelf you have, because we used to use it in the laboratory for laboratory work. And I want to take it over there to see Mr. Smith, and I'm just going to inject that little collagenase into Mr. Smith, and I'm sure he won't mind, and hospital won't mind, and Health Canada won't mind. You know, you can't do it that way. You have to show, first of all, this crazy idea works, which, of course, there's a huge amount of skeptics, and that's fine. That's the way it should be. And then you have to show that it's safe. And I mean, there's a whole road that goes with this. And had I known in the beginning what that road was, I'm not sure I would have. Embarked on it. But and just the first step, like you have to have a model. Like you can't. There's no blocked artery model that's ever been invented. So we actually had to invent the model first before we could even test it. So. There are some publications, and particularly the top one, this one, Circulation, which is a very highly regarded, high impact cardiology journal. These are the places that we published our early work showing that the collagenase idea works in these models, not in patients. And this is like a little bit of a picture of what that data looked like. So we had different doses of the collagenase, and we injected it into these arteries, and then we tried to open them with these guide wires, and the red are the success rates are so the higher you are, the higher the bar is, showing that you got through it, and the yellow is the placebo, and the red is the collagenase. And you can see that we're able to get through twice as many arteries with the collagenase. And in fact, the nice part is when you look at these experimental arteries, you can see that the wall of the artery was fine, just that we got through where the blockage was, and the placebo there. Yeah.
Well, it said before in the article
Yeah, it's interesting that doing angioplasty in an acutely blocked artery like a heart attack, there's two parts that make things difficult. One is that you have embolization or the clot can move, and the second is that you have acutely damaged heart tissue. It's a tissue that's with edema, it's swelling, it's very sick heart muscle. In fact, when you do angioplasty, whether it's in a totally blocked artery or in an artery that's not totally blocked, you can have embolization of material. Generally speaking, it's not the same as having a clot-filled artery. If embolizes, it's very small amounts. And because the heart muscle itself is not so swollen and sick and inflamed, it very rarely causes problems. And so it's not uncommon in a heart attack case that you open the artery, and because of the embolization or the movement of the clot, that the flow in the artery remains poor after you do it, and that's called no reflow. But in a heart that has no acute damage to the heart, and I don't think a lot of it actually does move downstream in this. Most of it just gets pushed against the wall by the stent, but it's actually very well tolerated, and it's extremely rare to have any flow problem after or problem in terms of blocking arteries downstream because of it. So, but it's a good question, and it's one frequently asked, and not just by you, but by regulators like FDA, et cetera. So it's not just you. So these ones just showed that we had very interesting rooms, but this is very early work, and just because it worked in there doesn't mean that you can then go ahead and just put it into Mr. Smith. So then what you have to do is a whole series of steps from there, and I'm going to simplify them in just a couple slides. And so I started in 1999, now we're up to 2003 to 2008. I call that the long waiting period. The first is you have to find a manufacturer that will make the collagenase for you in a form that you can put into patients. And that is not an easy thing to do. There's not a neighborhood collagenase maker on the corner of Yonge and Lawrence who's just waiting for you to come in there and buy it off the shelf. You have to find a place to do it, and they have to do it in a very regulated way with rules that you will not believe. If you thought it was complex doing a retrograde, that's nothing compared to the regulatory, okay? Second, we had a lot of regulatory challenges. So obviously, and you'll show you that what we did. Health Canada was, as they should be, as a regulator, wanting to protect the public, but on the same token, wanting to move something new forward. So they're in a very difficult position, and I really understand that. On the one hand, they do not want to hold back innovation, but on the other hand, they don't want to make anyone suffer as a result of it. And I can tell you from the early days of stenting that a lot of people suffered from the mistakes of the initial stenting experience. I was in Europe at the time, and I think if we would have the same experience nowadays, probably the stents, which I think have been a huge impact and great progress, they may never have cleared the regulatory hurdle because of the difficulties in the beginning. Next, you have to develop patents, because you have to try and commercialize this, or there really is no support for you to move it along the way. And finally, the finances, you got to find a way to pay for it, and that's, and also, there's not a place that's just going to give you money. So I'm going to go through this first. This is a look at some patents that I have on this from the U.S. Patent Office. Very challenging and very expensive. So you can see here that the U.S. patents alone cost $100,000. Outside the U.S., another $100,000. All this, by the way, was paid by myself and my working together. So that's the type of the commitment you have to have with something. It's early stages. If you can't get it from yourself or your family, you're going to have a tough time. Next, we had to find a place where we actually could make this. And GMP is the grade of collagenase. It's collagenase you can use in human studies. And this is a manufacturing facility in Israel where they actually make the GMP collagenase for me. And that's where we're working with. And then finally, regulatory. So you can see here the FDA. And I hope FDA does. I'm not sure if you're supposed to take pictures in front of the FDA. But I thought at the time I thought it was so cool going there, like, oh, I'm at the FDA. That's so neat. You always hear about the FDA, and I was actually. And this is Alison Manners, who works with me, and you can see this is just a visit to Health Canada just from a couple months ago with Alison and Laura C.H.A.R.G.E, who works with me. So based on that, I'm making a long story, still pretty long, but not still as short as I can. We proceeded with the first first-in-man human study, which we called the Collagenase Total Occlusion 1, CTO1 clinical trial. This was done mainly at Sunnybrook. We did one case at St. Mike's because I used to work at St. Mike's. I'm not sure anyone who here had seen me there, but I moved to Sunnybrook in 2006. And as you'll see, it's 28 patients, of which 27 were done at Sunnybrook. And it's called a phase 1. That's the initial phased trial you do. And looking at different doses. It was financed actually by the Canadian Institute of not heart research, it's health research. It's a mistake there. And I'm very grateful for the support I've had from the Canadian grant agencies over the years, both from the Heart and Stroke Foundation and the federal government one, which is called the C.H.A.R.G.E. And I think that to their credit, they have supported new Canadian innovation, and I'm very grateful for their support. And we looked at different doses, and that was really just a safety study, see if we could inject it in patients, and hopefully nothing terrible would happen. And as a side part, we want to see, well, is it going to be efficacious? Is it going to help us? And we started with a very low dose, one that we didn't think would have any effect, but it would be safe, and that's the dose we used was 300 micrograms, went to 600, 900, and 1200. And after every 5 patients that we injected, we had the data reviewed by what's called a data safety monitoring board. It's 3 cardiologists, and they review all the angiograms and all the patient data, and then they say, okay, you can go on and do the next one. And so as a result of that, we did 28 patients. And all of the patients that we did had 1 or more previous. So we weren't taking someone just to try on them. There were patients who had some significant symptoms, had a try using a conventional, traditional way, and failed. And because they failed, they really wanted it opened. And these patients were extremely grateful just to even have the opportunity to do it. In fact, I would receive many emails from all around the world for people wanting to come and try it. So this is how we did it. We take a catheter, and I'm just showing it. It actually embedded right into the chronic total occlusion itself. This is the first part of the occlusion. And through that catheter, we inject a very small amount of collagenase. It stays in there. We leave the catheter in there for about 25 minutes, remove it, and then we have to wait because it doesn't act right away. You have to give it, right now we wait overnight. So the patient stays in hospital, then we bring them back the next day and we try just like a usual way of doing an angioplasty. We may be able to do it in a shorter period of time, but this is based on our preclinical work, and I didn't want to change it because it worked very well in the preclinical work. This is one of the research nurses. This is us over by the table and the patient. And you can see that she's mixing up Elaine's mixing up the medication there. And I want to show you a couple of cases, okay? And this is a 48-year-old man who lives near Windsor, who unfortunately he's 48, okay? He already had his first heart attack at age 36, had bypass subsequently in 2005, has had many angioplasties, and he was having severe angina. He wakes up every night for the last year. For the last year prior to seeing it, could not sleep through one night without getting angina. And he had had a coronary occlusion from an angiogram that was documented in March of 2009, and they had tried about 8 months later and failed in London, and they sent him to us. Now, I'm going to try and go through this and just sort of try and teach you what it is, what we're looking at. Okay. That's it. Okay. Okay. So this is the circumflex artery there in the back. Can you see here that the artery stops? Can everyone appreciate that where it's stopping? Okay, it should run down here. It's blocked there, okay? This is the way the artery looked before we did it, okay? And I'll run it through for you. You can see the artery filling up later on there. Now this is a case that you couldn't even do by the retrograde because there's no connection to the other artery. Now, this shows us putting in the fine cross, this little microcatheter, and that's how we inject the collagenase in there. I'll stop in a second. You can see the dot there. Can everyone see that? And you'll see that the dot is actually into the occlusion. So the occlusion starts here, and so we've already got the dot in there. And look how far in it is, okay? Look at this one. It's a little bit into the occlusion. We inject the collagenase. We then bring the patient back 24 hours later. The occlusion doesn't look any different. You get a little bit of better flow. This is the end of the occlusion is here in the side branches. Okay, so the occlusion is from here to here. And right away, before we just put in the catheter, can you see how far that dot is in now? How it's already so soft that this catheter has migrated without doing no wire work at all. Of course we position it with a wire in there to start with. It has to go with the wire, and then we take the wire out to put in different wires to do the angioplasty. But it's before the dot was sitting there, and already it's just gone through there. And we put, with the first guide wire in a very short period of time, we're already right through the occlusion, almost getting back into the artery. And we just changed to a different angle of the wire. And you can see it now approaching that distal part there. Can you appreciate that? So it's now actually into that wire. So then we get it in, and now you can see we've crossed. Okay. And now this is what it looks like after. So we've recreated all those branches from doing it with 2 drug-eluting stents. Now, that night, this had his first night in over a year where he didn't have chest pain. And in fact, I think I can't remember. I think I was interviewed about something about it, and he was on the. If you look on the YouTube, you can see he'll talk about it. But 2 comments. One is that it's incredibly the feeling of doing something with your own hands and seeing it work in someone, you know, makes all that long period worthwhile, and it was very challenging. And the other part is you have to realize that there was an overnight between the time that I injected and when I come back. And can you imagine how well I slept that night, worrying about, especially in the first patients, when I had no idea. No, I couldn't call anyone up in the world and say, you know what, how does it work when you inject the collagenase? So I literally could not sleep for many nights in the first group of patients because, you know, you think it's going to be safe based on all the experience you've had, but when you actually have done it for the first time in a patient, and each time you change the dose, is there going to be some catastrophe overnight? Are you going to hurt someone? And as a physician, it's a heavy thing to deal with, and exciting when it works, but boy, there's a lot of anxiety about it. So this patient, he had a CT angiogram, and it was fine at 3 months. He had a full return to activity. In fact, about a year and a half later, he had more chest pain, came back for an angiogram, and the stents that we'd put in that artery were completely open, and it was a new blockage somewhere else. So the disease doesn't stop, but what we had done had been maintained and done very well. A second case, okay, and then we're getting close to the end here. I know it's getting a bit long. This is a police officer, and you really want your police officers to not have angina or shortness of breath when they're running after the bad guys, right? Like it's extremely important that and when you're 49 and you're a police officer, I don't think you want to retire yet. It's I think very young age. So he had some significant angina for several months. Went through all the usual investigations, and they had tried and failed with the first one. And this is actually from the first attempt at another place from December of 2010. And I'm going to show you. So there's the right coronary. See how it's blocked right here? And it reconstitutes here. So this is the blockage area in here. And this is how far they got the wire into that time. So they got the wire a little bit into it, but it had to go all this way and couldn't get any further, and it was very hard and couldn't get any further. So he came to see us, and we did this from the wrist, not through the leg. And you can see it looks pretty much the way it did before. And I'm going to get you see here that it kind of ends right here. There's a little bit of a run-in. And then there's the other artery, so we inject it, and you'll see us injecting. Once again, remember what it looks like here, okay? It turns the corner, there's a little pouch, and then there's nothing, right? Okay? So then we put the catheter in for the injection of the collagenase, and this is just positioning the catheter. And we made sure that we were into the occlusion. We came back the next day, and this is when we did the angioplasty. The first thing you notice is that there's now a puddle of contrast right here. Okay, that was not there before. So now we can see that we have contrast all the way, at least halfway through the occlusion. So we've created, even without wiring, a little bit of a channel in there as a consequence. And then we now use these bilateral catheters, see one in one artery, second one in the other. And that way we get to see the entire length of the occlusion. So now you'll see exactly how long the occlusion is. Let's see. I'll try one more time to stop at the right spot. Okay, so there's that puddle. There's the end, so you have to get through there. Okay, that's what we have to do. And in a very short period of time, like 9.5 minutes of fluoroscopy, we already had, and this, by the way, Fielder XT is the softest guide wire that we have. Before, they could not even do it with a hard one. So the Fielder XT is like the other one feels like a spear, and this one feels like a soft little. You can appreciate it. So then we put in a few stents, and this is the way he looked, and he was out and ready to get all the bad guys after that. So. Just a summary of what we did, even though we weren't really trying to, obviously I hoped that it would be successful. But in my opinion, if I had, I think 40% of the patients successful in the whole trial, because they all failed before, so they'd all failed. So I thought that would really show that there was some promise here. So we had all the patients were male, and usually most of the patients with chronic total occlusions tend to be male, like over 80% of them. And the average age of the occlusion was not 3 months, but it was actually over a year. And in 21 of the 28, so 75% of them, we were able to actually cross. So I was looking for 40%, so I was pretty happy that 21 of 28 crossed. And the other part that made me very happy is that in 85% of the time, we were crossing with soft guide wires, not with stiff ones that had been tried. So it really showed to me that the therapy had effectiveness because we were then able to get across with guide wires, either all of the occlusion or most of it. And at follow-up, the patients were doing very well, and there was no evidence of any bad stuff happening in the arteries or the heart, and we did follow-up, and everything looked pretty good. And then we were able to write up the results. Again, this is circulation, and that's in cardiology, it's the New York Times of cardiology. Let's put it that way. It's tough to get in there, so I was very happy with it. And where have we moved since then? Well, we finished it 2 years ago. Have tried to move the clinical part forward, and it's never an easy pathway. But now, as you will see, we're about to start, I believe, next month, what's called a phase 2 trial. And it'll be at 10 centers in Canada, probably 2 in Holland. And the principal investigator is actually not, now I have to take a little bit of a back seat because it gets to a point where, because of conflict of interest, I have to start letting other people do it. And Dr. Chris Buller, who works at St. Mike's, an excellent interventional cardiologist, expert in CTO, he's going to be leading the trial. We're going to have 2 doses, not 4 this time, and we're going to compare it to a group of patients getting placebo. So it'll be blinded. No one will know what they're getting. Total of 90 patients, and I expect that we're almost approved at Sunnybrook to start, so it should be next month. And Health Canada approved it about 2 weeks ago, and this is actually the letter from Health Canada. It's called a no objection letter. They don't say we approve it. Everything's a little bit negative in this world. It's like, no, you can go ahead. But, okay. So anyway, that we're very pleased that, and Health Canada, I want to say that how you can rest easy that your Health Canada is doing the job for you. I've had several meetings with them over the years. They get it because on the one hand, they know that patient safety is paramount, and they have to do that. On the other hand, they really want to help Canadians with innovative ideas, try and progress them, and they have to balance the two. And they're very thoughtful about it and very collaborative about it. And sometimes you always hear about federal employees or these agencies being out of touch and and that is not the case. I think we can be very proud of how the way the government agency of Health Canada has worked, and I found them to be really very, very good partners in looking after all the issues and doing things in the right way. So I want to almost conclude here with showing that this is experimental, what it looks like a happy face. Improved guide wire crossing technologies make everyone happy. And finally, hopefully my goal will be reached. And this is a picture from today's hockey game. You may notice the Canadians celebrating there. And just acknowledge a small number of the people who have helped me along the way doing it. So anyway, I want to thank you for your attention. It's been a bit longer than maybe you hoped for, but thank you very much. So the question was, if collagenase is so good, why don't we get a pill and just take it and keep arteries nice and clean, right? And first of all, the collagenase is an enzyme, and most enzymes you can't swallow. There are some you can, but many of them get inactivated in the stomach because of the pH, etc. The other part is that you won't get a high enough concentration where you want it to work. And I want it to be right at the site of where the arteries are occluded. Because to be honest with you, by itself, most of the time when you inject it and you come back the next day, it doesn't look that much different. It's softer. Like the properties are different, but in order to make it look different, you probably have to give such a large amount of the collagenase that you could potentially harm the artery. So at this point, it's a local therapy because it's really the only way you can get enough of it there and not do anything bad somewhere else. So for me, the goal would be to try and do it as a same-day procedure, to be honest. That's what I'd ultimately like to see, that you deliver it some way, you get it to work in a few hours, come back later in the day and do it. So that would be much better. So it's exactly like doing angioplasty. We take a guide wire, and we have these. Instead of a balloon, it's a catheter. So there's no balloon on it. It's just like a tube, and we get the guide wire into the artery where the blockage is, right up to where the blockage is. Okay, and then over that wire is a tube. Okay, and it just tracks the wire because it's hollow in the middle. And once you get into the occlusion, you just try to advance it the first millimeter or so into the occlusion. And once you're into that spot, you pull out the wire, and now you have a beautiful drug delivery tube, and you just inject outside through that little chamber into the collagenase. It's a small amount. It's only about 1 ml that we inject. The likelihood of the collagenase getting in the bloodstream itself is well, it's not zero likelihood, but it's not high, because first of all, it has to get through that occlusion back into where the bloodstream comes back, unless you make a mistake and you inject not into the occlusion itself, but a little bit before the occlusion. There may be a side branch. So one of the things that we have to do as part of the safety profile is we collect blood samples, and we measure them for whether or not we can detect the collagenase in it. And that's part of the ongoing regulatory part of it. It's unlikely, though, that the particles, and I tried to mention it before, that even though the collagenase softens it, it doesn't break it down to the extent that there's a ton of, like, it's not like sand you're making in there. It's just softer, and usually everything is just pushed up against the side by the balloon and the stent. The pressure, whatever it is, would get much lower, to be honest with you, as it goes through this long resistance area, because of it's very narrow. I mean, these are big arteries, and if you get even a little bit of a channel through there, they're very, very small. So it's unlikely that from the injection itself that you would get stuff into the blood. However, it is potentially likely that either through the injection, either you do it incorrectly, which that's part of the, we have to teach everyone. And in some cases, it may be hard to even push it into the plaque. Or when you open it up after you've treated it, that some of the stuff may break off. That is a theoretical possibility, and one that we're tracked. We haven't seen it so far in the 28 patients that we did, but it's possible. Yeah.
Has anybody been allergic to collagenase?
Yeah. So that's a great question. So for instance, there was a medication we used to use for heart attacks called streptokinase, and we stopped using it when there are newer agents that came along that were more effective. And because many people have streptococcal infections when they're younger, it's very common that there was sometimes there was a risk, and there were a few cases of hypersensitivity reactions or allergic reactions to the streptokinase. So it did happen. However, because this Clostridium histolyticum, this bug, actually it very rarely causes human disease, very rare, and we're only going to allow people to give the drug once. So it is possible if they had a second exposure to it that they could have an allergic one, but because everyone is really the first exposure in this, that it's unlikely. So, and we have not yet seen anything. And to be honest with you, it's been used. Do you know what Dupuytren's contractures are? Do you know these tendons in your hand get thickened, and you sort of get this flexion deformity of your hand? And anyway, so collagenase as a completely separate thing. I never even knew they were doing it until it was very far along. They've also injected the same, not the same company making it, et cetera, but they've injected into there, and in all of their safety data, there has not seemed to have been an issue. And they've injected it several times, so I think it'll be okay. A very good question about what the regulatory process is. And the FDA is a body that is very careful about new devices, new medications. And there's typically, like the phase 1 is just getting the first experience with it, and often it's in healthy volunteers. Obviously, you're not going to inject collagenase into a healthy volunteer, but these were patients who really had no other option. The phase 2 is really to get more safety data so that you have a greater experience in terms of number of people that have been exposed to it, and as well, by doing a placebo arm, you start to have some idea of the efficacy compared to placebo. So. And that's typically sort of 60 to 100 patients, so depending on how quickly you can recruit it. We have 10, 12 sites, we expect it should be in a year or so. And then the phase 3 is when you really try and prove the efficacy, that it works. And that would probably, we've looked at, it's probably going to be about 450 patient trial for us. So we're probably, like we're in phase 2, and to be honest, when you're looking from a lens of 1999, I feel like I'm pretty far forward along in it, but there's probably a few more years yet before we get to the point that we get through the phase 3. Yeah. So far, the dose we picked, and we didn't just sort of come out of this dose out of the hat. It was based on a fair amount of preclinical work, and a higher dose may be more effective in these arteries, but on the other hand, safety to me is everything. So I'd even be willing to sacrifice a little efficacy in order to ensure that they're safe, because that's to think when you do something good for a patient, you feel amazing. When you do something that harms them, it's equally intense, believe me. So placebos are absolutely necessary to really check drugs out. On the other hand, if you're the placebo patient, you kind of feel like, well, I took all the risk of this whole trial and I'm not even getting the agent that may be helpful. And there are many examples in cardiology where drugs or procedures that we thought were really, really effective turned out to be placebo effect and not. And the greatest example, I don't know if you, we haven't seen the publication of it, but recently there's a new catheter that we've developed for patients with high blood pressure that you do what's called an ablation procedure in the arteries to the kidney, and the data look phenomenal. And recently a report has come out that it probably is not, because they hadn't done a proper placebo trial until now. And this was a multi-billion-dollar industry. This was a huge thing. You'll probably hear about it more in March when it comes out at the heart meetings. But so they're necessary and they're important. And the nice thing about my stuff is that it's easy to do a placebo, because you can blind the operator to the drug because it's just in the vial, and it's easy to give a placebo. So when we had the discussions with Health Canada, that's exactly one of the points that came up. Like, what about the poor patient who agrees to go into it but gets a placebo? Is there a way that you can give them a second try with the drug? And in fact, we have come up with a way of doing that doesn't disrupt the study. So we are definitely trying to do that. The beauty of this is that you use the techniques and skills that you have that you use every day. So interventional cardiologists, I think the injection is something that we don't usually inject things into plaque. That's a little bit, it's not hard to do, and I'm sure I could teach it to any experienced interventional cardiologist in a brief period of time. But the way you do the angioplasty the next day is the same way that everyone does them in the usual. Yes, yeah, because you got to, now you got to open it. Like, all you've done is soften it, so now you got to go and do the work.
Sorry, not what I meant. So if you went through the arm,
Okay, yeah.
are you going to
So the way, that's a great question. So first of all, when we inject it, we only need one site to inject it, right? You don't need two different places. Remember I told you that sometimes we need two catheters? So we go in, let's say, the wrist, and get the catheter in place, inject it, and then the next day, we either go back into the wrist and another, about some cases, you don't have to have two catheters because you can see the collaterals from the one, but most of them you have to have two. So we do this one for the injection, the next day come back and do two, and usually we'd use the same site again. Chronic total occlusions, by their very definition, are not really acute problems, right? So they're identified at the time of an angiogram, so you usually don't know anyone has it until they do an angiogram. And like I said, it's kind of chronic symptoms. Most of the patients have, angina, shortness of breath. It's not often the typical symptom of chest pain. A lot of these patients, you see, what the main symptom is that they get winded a lot, and somehow they don't have the same symptoms of chest pressure as patients who do not have CTO. Some do, but much more frequently, I notice now, you see the problem with them walking. And so you have, usually the angiogram comes, and then either someone tries them who gets it or doesn't get it, and then they often contact us about the trial. And now that, I haven't done it for about 2 years, because we finished the first trial, and then it takes all that time just to get the stage set to do the second one, in terms of you have to raise finances, you need regulatory approval, you need Health Canada, you need all the stuff you have to do, and it takes time to do that. So now that we get started, I'm hopeful that my colleagues at different hospitals who either, if they don't want to try them or try them and fail, will then refer them to us. And in Toronto, it'll be done at UHN, Dr. Javik, if you know him. He's a friend and colleague of mine, and Dr. Buller at St. Mike's, and us, and probably at South Lake as well. So we'll have various sites working. So hopefully, if people have those patients, they'll send them to us. I hope so.
Doesn't when that artery become completely blocked, you're coming in with a heart attack?
No, that's different. You see that there. I tried to, and I hope it was clear. And if I apologize if I missed this, that if you have a sudden blockage of an artery, like it was open and then all of a sudden it blocked up with a clot, that's an emergency. That's an acute heart attack. Patient comes in with bad chest pain. The ECG has typical findings, and that's a medical emergency. You got to get them in there and open it. When I'm talking about these blockages that have been there for a while, and they have not resulted in a heart attack because there's enough other blood supply from the other arteries to the territory, but they get symptoms. And so they usually come to you saying, you know what, I've been short of breath for the last 6 months, or I've had chest pressure. They don't, it's not a medical emergency like an acute heart attack. So how did I come up with the idea, like, of all these things? Yeah. So it's a great question. So I did a lot of work for many years on restenosis, on why arteries block after balloon angioplasty and after stenting. And in the mid-90s, I started studying these enzymes at that point because they're actually involved in restenosis. Not so much the collagenase one, but it belongs to a family called matrix metalloproteinases. So it's a big family of enzymes, and collagenase is part of it. And I remember at the time when I was working on it, and I started to have the clinical failures of doing chronic total occlusions. And you know, when I fail something, I think about it. I think about it all the time, and it just I'm probably not a great husband because I'm sitting around thinking like, why did my last thing not work? And it obsesses with me. And so then I started trying to think about it logically. Well, what is it? So then I knew actually it was collagen because there had been studies in the past with pathology, and because I knew about these enzymes from my previous work, for me it wasn't a huge leap to put one into the other, but then trying to actually operationalize that idea turned out to be quite challenging. Some of this, you can tell, I'm very passionate about it, and it's important to me. And there are stages along the way where there was long lag times where nothing happened, but I never lost the commitment to it. And I just always, if you do these procedures, let me tell you, if you do them and you're a chronic total occlusion angioplasty doctor, you're in there for sometimes 3-4 hours, right? These sometimes are hard. You have to be a very patient person to stand there for that long and keep trying. And those who may have been in procedures with me know that I do not give up easy. So that type of personality probably fits very well for trying to do this. But and now I'm getting close. I'm getting really clse now. So. Nice to see you there. Thanks.
A wonderful note to end. Dr. Strauss, thank you very much.
Okay.
Thanks a lot, Brad. Appreciate that.
Yeah.